The conference is being recorded.
Join the call to today, but if you need help with communications@bcadu.org.
Can't
Link
hear.
and email to you. Have somebody here for that. In his presentation today, Dr. V will discuss the origin and functions of opioids, the opioid epidemic, both past and present, followed by a discussion on treatment. Questions after, both online or are on the chat as well as personally here. I'd now like to introduce Dr. Harry V. He is the former Chief of Addiction Medicine at one of Canada's largest inpatient treatment units. He has been practicing addiction medicine for over 15 years after experiencing addiction firsthand. Today, he continues to work in the addiction and recovery on the front line at methadone clinics in his hometown in Hamilton, Ontario. Thank you, Harry.
Thank you very much for that introduction. Good afternoon. I wonder if I can have the next slide, please. So today I'm going to give some perspective on the opioid epidemic. I think it's more of a reflection. We're going to cover some topics in a very general way because there's a lot to cover. So I'll try to give you a taste of certain aspects of opioids and addiction and the crisis that we're facing right now. Next slide, please. I do have some disclosures. I am a consultant for Indivud. I have not received any funding for this presentation. Second disclosure that I want to say is that I am 18 years in long-term recovery from IV opioid use. Now, the reason I say that is for two reasons. One is the silence of people who are in long-term recovery allows other people to define us, and also what I perceive and many others do perceive is the growing pessimism of successful treatment and recovery. The second reason is because I will use terms that some people say they find offensive. I do not. I will use the term addict, addiction. I think the regular parlance is substance use disorder, but that doesn't really give you an idea. The term addiction or addict comes from a very old word, addicere, used in Rome, in ancient Rome. It's the Latin derivative, and it was used with respect to being beholden to a debt. That means you are a debt slave. And I think it aptly describes the process of the disease of addiction. Next slide, please. So some of the talking points, very, very briefly, I'm going to look at the opioids and their functions, the opioid epidemic past and present, and look at treatment and recovery, and then some concluding remarks. Next slide, please. This is where it all starts. Papaver somniferum. Known in antiquity as the Persian poppy, it contained opium. It's been used by humans for thousands of years. Next slide, please. It made its way east and west through the ancient trade route known as the Silk Road, and from the ports of Antioch, Palmyra, and Tyre, made its way to ancient Greece, then to Rome, and in the Middle Ages by the Venetian Empire and to the rest of Europe. Next slide, please. Now, the ancients knew not only the medicinal benefits of the poppy, but also its dark side and its danger. Here are the Greek gods, Hypnos and Thanatos, the gods of sleep and death, twin brothers. They were always depicted with a crown of poppies. So people knew not only the benefits but the dangers of opioids. Next slide. In the 19th century, we were able to identify the three compounds that make opiate or opium, the active compounds of opium that made it so potent. That was morphine in 1804, and in the 1830s, codeine and thebane. These are called the opiates. But what are opioids? They're different. Next slide. In order to increase the effectiveness of the natural opiates, to decrease side effects, and also to try to avoid their addictive potential. Scientifically, they try to alter these substances. Now, there's semi-synthetics and synthetics. The semi-synthetics are basically manipulations of the organic original compound, such as morphine. They transform it into heroin and it's called diacetyl morphine, so by adding different compounds. Now, the synthetics down below are ones that are completely scientifically made in the laboratory. Most famous ones are Demerol, piperidine, methadone, and fentanyl that we all are aware of today. Now, next slide. Basically, what these compounds and the manipulation of these compounds, and before I go on, now we use the term opioid. We use the term opioid to describe not only the natural occurring opiates, the synthetics and semi-synthetics, but also our body's endogenous endorphin system. So we all call them, technically now, opioids. Now, our natural occurring endorphins are released for reward and also for decrease in pain perception. So we all call them now opioids. Now, in most cases, roughly speaking, with the manipulation of the original compounds, they became far more potent. This is a generalized example of their potency using morphine as sort of the standard. Now, you'll see different numbers and different charts, but it's just to give you a perception that they are far more powerful, especially those that have been manipulated or synthetically made. Next slide, please. Now, not only does the compound, the way it is structured makes it potent, but also the route of administration. The thing, if you can get the thing into your bloodstream quickly into the brain, it becomes far more potent. For example, the red and the green, both intranasal or inhalation and IV, gets into the bloodstream very quickly, and therefore it makes its effect very, very fast, and it's very potent. Orally, it takes slower. Also, as far as IM or intramuscular injections and subcutaneous, again, very slow. Next slide, please. This is a nice representation of what they call the LD50 to show you the potency, the relative potency of medications. LD50, basically what that means is if you give it to a bunch of people, 50% will die. So that much heroin will kill you. 50% of the people that take it, that's how much will kill them. Fentanyl, as you can see, much less, and of course the carfentanil. I think there's like 1 or 2 grains in there. This is a really good representation. Next slide, please. Now, the opioids were quite a breakthrough in medicine because we didn't have much, and to relieve pain was incredible. Now, the opioids, their major sort of sites of action are the brain, as you know. They are excellent not only in controlling pain from the periphery, but also to decrease the sensation or the emotional component of pain. Also affects the brainstem to bring down the heart rate and the respiratory rate, and also for the cough reflex, because they're used to prevent, as antitussives, to prevent cough. Unfortunately, too much, of course, when it hits this center, will cause you to stop breathing and die. Also, in the spinal cord, the anesthetists are well aware of this, especially in the dorsal horns, where they can apply analgesia. And the peripheral nervous system, for pain, for most types of pain, where we perceive it, is the opiates can modulate this. And of course, in the intestine, one of the side effects, of course, of opiates are constipation, but it was used to treat diarrhea in the past also. Next slide. Basically, how do they work? Just really in a general sense. On the left, this is a neuron. Neurons carry messages. Basically, the neuron itself is slightly negative compared to the outside, the extracellular fluid, and with the movement of particles in, it shoots a neurological message, if you will. Okay, it's a chemical. It's a movement of chemical cations, positively charged ions inward in order to send a message down the stream. Opiates interfere with this. I guess the best and most crudest analogy that I can give you is think of a neuron, okay, transmitting a message, much like the water tank on your toilet. The potential is there in the water tank. You flush it. That's the message. It goes down. There's a refractory period where the water trap closes, and it takes a while for the tank to fill up before it can fire it again. What opiates basically do is keep the water trap open so that the neuron cannot fire. And the transmission of a message from the periphery doesn't get to your spinal cord, your brain, so you don't feel the pain. That's what's so beneficial about them. Next slide. Another area that they work in, which is also beneficial, can also be deadly, is within the brain. Within the brain, what opiates do, you see on the right, there's an opiate receptor there. There's something called GABA. GABA is a neurotransmitter. And in the brain, GABA sends messages to a certain part of the brain, and we'll see it in the next slide, in order to keep dopamine, which is sort of our pleasure drug, if you will, the rewarding drug. We'll talk about dopamine again in the next slide, from firing. Now, when you use opiates, what it does is it stops GABA from firing. In other words, it takes off the brakes, and so dopamine rushes into your brain. And it gives you that sensation of calm and pleasure, what we usually call like the high, but it's very beneficial, especially in pain control, because it takes away that emotional component. Next slide, please. I'm going to spend a little bit of time on this slide, because this is an important slide, because I talked about the beneficial effects of opiates. The VTA, the ventral tegmental area, as you see there in the green, in the center, is basically the way station for all drugs of abuse. This is where the dopamine neurons that release dopamine are located. Every drug will affect it. Now, in a case, let's say, with pain release, you take an opiate, what happens is dopamine is released into the amygdala, which is involved in negative emotions and also memory, so it calms you down. Away that anxiety. Also to the nucleus accumbens, which is basically our reward center that says this is everything's okay, and to the prefrontal cortex, which is actually a part of our brain that is able to make our own decisions. It's our conscious self. It says things are going to be all right. This is the danger. Danger with opiates. Let me take a little time to do this. Let's just look at the brain in two areas. The prefrontal cortex, as I mentioned before, the prefrontal cortex is actually the seat of your soul. It is the captain of your brain. It will tell you what's right or wrong. It will make you think things through, different judgments. The center part, where you see the ventral tegmental area, nucleus accumbens, and the basal ganglia, that's basically called the limbic system. What is the limbic system? The limbic system is a very, very old part of your brain. It has our desires, our fears, our motivations. It's a record of our memories. Now, it's subconscious. And it will react very quickly because evolutionarily, we needed that. And it's the prefrontal cortex that sort of takes the information and says, okay, what do we do with this before it makes any form of action? Now, what happens to people that are genetically vulnerable to addiction? Understand that addiction is not the scope of this talk, but addiction has a very high genetic predisposition. At least 50% of what you see in an addict is genetically determined. Now, most people, the old thought was, why do people take drugs? Well, they take drugs because it goes to the ventral tegmental area, it goes to the nucleus accumbens, they feel pleasure. It's a great burst. It's very hedonistic. That's not true. Actually, they found it's not true. Anyone who has worked with addicts for many years find that addicts aren't having a good time coming to see you. They will have many plausible reasons sometimes that appear plausible why they're using, But if you actually ask them, they have no idea why they continue using it. Why is this so? What they found is when an addict takes a drug, there is no dopamine rush. Now, dopamine is very important. It gives us pleasure. It also motivates us. It is the one that recruits all parts of our body directed towards a goal. It's what gets you up in the morning to get that coffee, get dressed, and come to work when you don't want to. Okay? Now, what happens in an addict? There is no dopamine rush. So what have they found? They found that with repeated use, what happens? The limbic system becomes hijacked. The effect is so powerful in these individuals. The limbic system, which is there for your survival, identifies it as a substance required to sustain life. And even far more sinister is that the dopamine, which is required in order for motivation and to think things through in the prefrontal cortex, which is your captain of your ship, if you will, what they find is that the dopamine receptors start to disappear. A pruning begins, a rewiring of the frontal cortex, so that the last line of defense is removed. So what happens? The limbic system is operating at a subconscious level, and it has something called the incentive salient. It will look for cues, memories, emotions, smell, sounds that will say, okay, it's time to use. It will recruit the body to use, to go after that drug, while at the same time completely dismantling the prefrontal cortex, being able to stop that person. Basically, that person has lost their free will. That is the hallmark of addiction. The hallmark of addiction is the loss of control. That's why it's so difficult to treat. Studies have shown that pruning of the prefrontal cortex that controls your ability to do compulsive acts that may kill you or harm others takes about a year to return. Not fully. The areas are lost, but side growth, synapses or connections. It takes about 5 years of absence from a substance before the risk of relapse drops to about 15% or below. You're dealing with a very sinister and cunning disease that is operating, and the person that has it isn't even aware of it. Next slide, please. Now, opiates have been with us for a long time, and they used to be legal, completely legal. You can buy them at the corner pharmacy. You could send away for them. Catalogs. Here's heroin. Buy it by the ounce, $4.85, and cheaper in greater quantities. What you see next to you is heroin cough drops that you can carry around with you. Next slide. This is in the 19th century. Paregoric. We used to use it for colicky babies. It gives you the dose. 3 drops for 3-day-olds. How's that for you? 40% alcohol and has opium. And the drug of choice for most females in the 19th century was laudanum. They were used in patent medicines. Heroin was used to treat cocaine and alcohol addiction, thinking that it was not addictive. Next slide, please. And then this happened. In 1850, we have the development of the hypodermic syringe. You could order this, actually this syringe set, you could order it by mail over catalogs with 2 needles, a syringe, and your starter kit of morphine. What happened was with the development of the hypodermic syringe, the technological development, the development of purified, very potent opioids, and some people don't know, that in the 1890s, globalization and global trade was profound. We're getting close to what it was like then. Now, some say, they haven't reached it yet. Had this influx. Opiates that started to devastate communities. So the opioid crisis has been occurring since about 1870. Next slide, please. The Canadian doctor, someone that I admire, actually. He has an earlier paper from 1884 talking about the opiate dilemma. And this is 1891. He was actually the medical director of the Homewood Sanitarium up in Guelph. He's calling on the medical community that there is a big problem. Maybe we can control it. Maybe there's some areas we can't. So it's been with us for a long time. Unfortunately, the decisions made back then proves to be quite catastrophic. Addiction medicine, which is just coming again into prominence, was quite a force in the 1890s. Treatment centers all across the United States. The Homewood Health Center is one such here in Canada. By the turn of the 20th century, it collapsed and died. We can talk about that, why that happened. There's many reasons. The problem has been with us for a long time. Next slide, please. Let's just look at data right now. This is, now, with every data, there's always going to be difference in numbers. But these are the number of deaths. I think what I want to bring to attention is Ontario, of course, the number of deaths. But what I really want you to look at is the center column, the numbers there. As you can see that from 2010 to 2015, the amount of fentanyl that's been implicated in deaths has increased compared to the others. So now it beats the other ones out. And oxycodone, which is the OxyContin component, after the formulation change that occurred a few years ago, has started to decrease as far as its use. So we're having the same things today that they had in the 1890s. We have an importation of a very potent crystalline substance that can be easily transported. We have increased trade, and that technological advancement, along with increased globalization, is bringing it back to the forefront. Next slide, please. These are the confiscation from police forces in the last 6 years, and you can see that the samples of fentanyl seizures has grown dramatically. Labor the point, we know that. Law enforcement has been very good at this. I always hear people say, we lost the war of drugs. No, we didn't. Difficult war. But the police forces are doing quite well, the best they can. It's now up to us to help them out. Next slide. This is again a representation of the death rates per 100,000 in Canada. As you can see, and we all know, increased as you head west. There is increased concentration of deaths per 100,000 people. Next slide, please. Now, this is a breakdown of who has died. Who has died. This is from January 2016 to March 2007. If you look at Ontario, about 2/3 of the deaths are male. So the majority that die are male. And I don't have it on this slide, but the age group that is dying at the highest rate are males between the ages of 30 and 39. That's not much of a surprise. We know that the average death rate of drug addicts, the average age of death is anywhere between 30 and 35. Males tend to be the ones that tend to die. Whereas alcohol is around the age of 50. Next slide. Before I go on, I think we have to put this into perspective, too. Opiates are a problem, there's no doubt. And this is no way to take away from the problem that we're facing. Let's look at alcohol. Best numbers they have, and this is deaths, medical complications leading to deaths directly attributed to alcohol. 2004, they have the best numbers. Approximately 12 to 13, so approximately one death every 2 hours due to alcohol alone, 24/7, 365 days a year. Approximately 12. Now it's about 12 to 15 people will die of alcohol. Medical complications related to alcohol alone. That's profound. That does not include suicides, homicides, or traffic accidents. In the United States, half of the homicides are completely attributed to the use of alcohol. Also, in 2015, 2016, 56,000 patients were admitted to hospital across Canada because of alcohol alone. Some of them came to emergency more than twice, a total of 77,000 hospital visits, greater than the number that visited hospital because of heart attacks. So opiates is a problem, there's no doubt, but so is alcohol. So let's keep things in perspective. Now, the road to recovery. This is going to be a difficult one to cover because no one does research on this. Now, William L. White, who's a consultant down in Chestnut Health Service in the United States, has been doing research on this. But you go to any city, they can give you the exact details of how many people died up to the date that they're talking to you. But do you know how many people actually got into recovery in the last year in this city? I'm not just talking about abstinence. How many people in the last 12 months in Brantford no longer fit the DSM-5 criteria for a substance or an opiate use disorder? Does anyone know? No. And that's tragic. That's tragic. We don't. Well, let me just give you some ideas, and then I'll wrap up. Next slide, please. Road to recovery. Now, the DSM-5, they use this to determine whether you have a substance use disorder. Of course, we use this, but addiction physicians use this as a bit of a guide, because we look at addiction in three ways. We have the abusers. Those are the people that sometimes will use it when they go to parties. It can be deadly because they don't know what they're taking. But they are amenable to education. It is a behavior, a mature behavior, or a behavior without good thinking. Second, there is dependence. Dependence is a normal physiological response to an external substance. If I were to put you all on morphine for 2 weeks, you'll become dependent on it. I'll withdraw it from you, you'll experience the withdrawal, you may feel uneasy, but then you go on. Addiction is a different beast, just like I said before. It is an altered state of sobriety where there has been a genetically mediated change in brain circuitry that is active, even when use, withdrawal, and tolerance are no longer operating. The hallmark is a loss of control and also the craving phenomenon. But we use this to determine severity, but not that often. So you have to first, identification is important because you got to know the person you're talking to. Because saying to an addict, just say no, isn't going to work. Because I'm sure they would have thought of it before. Okay. But to an abuser, a young kid that likes to go to a party and pop a few pills, just have a good time, say, don't be a slow learner, those things are bad for you. Next slide. Okay, emergency rescue and harm reduction. These are important things. A lot of times when I talk about recovery, people say, well, you don't like to talk about harm reduction. No, I do. Harm reduction is to save people. But we've got to be clear that it's a short-term solution. Boston, they recently looked at people that were rescued by the, as you see, the naloxone kits. 10% will die within a year that have been rescued. It's better than 50%, better than 60%. At least we're doing something, but it's a short-term thing. Harm reduction also strategies in order to prevent other medical complications. The main thing that I see harm reduction is let's keep people alive and engaged and hope. We have to have an endpoint, though. We have to have an endpoint, try to get them to some kind of treatment. Next slide, please. Also what I see as short-term is detoxification and stabilization. Now, this sign here is where in the heck do you go? We've got all these different points of entries. We've got families bringing people to their family doctor. Family doctor, what do? So the hospitals usually become our detox centers. Jails sometimes become our detox centers. We have too many points of entries and nowhere to send them. One thing I do not like, and it's historical, and I understand that, is when they say non-medical detox. It's like going to a non-dental tooth extraction place. I'm sorry, but I understand the history. Physicians, both medical and psychiatric, really treated addicts very badly. Not only clinically, but also otherwise. And have done some really terrible things. But I think we need to have some kind of point of entry. So detoxification stabilization, we have the way to do that very well. Look, I've treated over 6,000 patients. I detoxified and stabilized many. That's the easy point. Next point. Next slide, please. Another thing that I see as short-term, believe it or not, is inpatient or outpatient treatment. You see, initially, and it was Marty Mann, I think. She was one of the first women who got clean and sober with Alcoholics Anonymous, who really, really pushed the United States to change the concept of addiction. Saw treatment as only part of a greater scope of support. Unfortunately, today, treatment has become the focus. Treat somebody, they're in a nice, safe environment, then you send them back home. What do you think their chances are? Seriously, without taking care of other things. And some people spend a lot of money. And this is where the pessimism occurs. Because I'm sure each one of you may know of someone who's gone to treatment and it has not worked. But inpatient, outpatient treatment is important if it has a long-term aftercare program and supports. And that's, if you're going to send anyone to treatment, that's what you look for. We have to take care of also psychiatric and medical comorbidities that do come along with this disease. Opioid replacement treatment. I didn't say opiate-supported treatment, because sometimes there's some people this is all they need, believe it or not. They have good enough, what we call recovery capital supports around them. And this will be sufficient, but for others it's not. And again, I see that as short term. We have to have something far more comprehensive. Do these things work? Absolutely. But not just on their own. Next slide. Next slide, please. That's basically short term. We've got to look at something long term, because we know it takes about 5 years for someone to reduce their risk of relapse. I'll tell you where the data comes from after this talk. Long term. What I am a real proponent for is what we call recovery-oriented systems of care. Next slide, please. It's a coordinated formal-informal network where the community itself comes together to provide a supportive base for recovery, not only to the addict, but also to the family. I'm going to tell you, it's easier being the addict than it is to be a family member of an addict. And they need support too. And it looks at all aspects in order to support. Now, treatment is only a minor aspect of this. Next slide. This was developed to actually for the destruction that occurred in Haiti, because there was quite a problem with addiction there too. The patient and the family is at the center. We're looking to not only use the resiliency that some people have on their own to identify those, but also to help with aspects that put the recovery at risk. What that recovery will look like, I don't know. As long as their life is getting better. And they become people that feel that they are productive and contributing not only to their own health, but to the greater good of the community. Next slide. Now, that's a very utopian view of things, but it is possible. Look, every solution is going to have some kind of trade-offs. Something I think that every community should try to at least endeavor. I know there are people in this room that are doing that. Ernest Bishop, Dr. Bishop, he was a physician, or you call him an addiction physician today, who worked in New York City in the jails and in Bellevue. This is in 1920. It was after the Harrison Act that was put in play in the United States in 1914 to help with the opioid crisis at that time. And I think this is how I'd like to end this with the next few slides, is he said actually what we're talking about today. It says the laws themselves are not so much to blame as a total inadequate meeting of the clinical and therapeutic and educational needs of the narcotic drug situation. The community. We have too long let the police officers, police force, and law enforcement be actually our treatment. And they need support. And that's from all aspects. And that's why I said that public health is extremely important. But also, to look to an investigation of scientific and other qualification and experience of those whose utterances or writings influence medical and lay opinion and action. In other words, question me. Don't take everything I say at face value. If someone tells you they have the solution, I'm going to tell you run. Question the people that are actually giving you the advice. Collective, this education is largely indirectly responsible for illicit drug trafficking. And I think prevention is very important in getting the message out there. Next slide, please. Mark Twain. I think this is one of the most profound things he ever said. He said many things. It's not what you know that gets you into trouble. It's what you know is for sure that just ain't so that gets us into trouble. I think that's one thing we got to be able to actually question our beliefs. Because we're in for a really, really interesting time. Next slide, please. This is the death rate, very small right now, due to cannabis. Not that cannabis was in the urine drug screen, but actually it was toxic levels. 287 people dying of cannabis isn't much. The LD50 has been greatly exaggerated because people don't think it's dangerous, but it is. 2 grams of pure THC, 2 milligrams of pure THC will kill you. But more profoundly, this is a topic for another discussion, is THC does something to your body. It disrupts the natural endocannabinoid system in your body that protects you against the effects of drugs, therefore making you more susceptible onto other drugs, and that's been shown. Thank you. I hope this was informative, and I'm open for any questions.
Do we want to have questions from the floor if we don't have any from the audience?
Sorry, I think I went a little bit longer than I anticipated.
Yeah, but that's okay.
I have a question.
Yes.
Currently, are you, if you are working with patients to help treat them for, is this in a sort of larger capacity? Like you mentioned, the supports that would need to be. So, are you part of sort of like a team that offers those kinds of supports, or how do you treat patients?
Very good. Okay. First of all, I was an inpatient for many years. Okay, and one of the things that bothered me about inpatient was, don't get me wrong, I think it's really good if proper things are put in place, is then we send them out into the abyss. Right? Now, right now I'm working, and as far as matrix, there's no matrix out there. I'm going to tell you, I'll give you an example. I work in a methadone clinic now, and many have never seen, like I'm certified by the American Board of Addiction Medicine. I made sure that I got the training I needed. I was lucky that 6 of the 8 original founders of the Canadian Society of Addiction Medicine actually were my mentors, which is fantastic. So I work in a methadone clinic. And there aren't any supports out there, really. And this isn't something unique, let's say, to Hamilton. Right now, for example, if someone was to have chest pain and fall on the floor, a whole system will kick into action. We know exactly what to do, the emergency aspects, the stabilization aspects, then the rehabilitation. Someone says, hey, I got a cocaine problem. What do you do? So what I do with these patients, and actually the place I work, and I'm not going to endorse any place because I'm not here for that, is I like the philosophy. The philosophy is to make the physician obsolete. I'm here to get you well, try to connect you with what I can, try to do as much as I can myself, because I've treated a lot of patients. I've done a lot of group therapy, individual therapy, and eventually get you off everything. You don't have to see me anymore, and you can go out and live a good life. And that's the best we can do. It's very frontier medicine, unfortunately. See, we are behind the Americans in many ways, and certainly behind the Europeans. The Americans now do have a specialty in addiction medicine. Canada doesn't. So they classify us as addictionists, but really don't know what to do with us. Now, will that change? Yeah, there are people that are working towards that, but that was a good question. So you do the best you can. Now, when I was invited to come here and talk and hear what's going on, well done. Like I think, this is the beginnings. This is how it starts. And it can't be just treatment. I'll give you an example. One of the things that I was known for treating, and actually I presented at the British Medical Association on this in 2008, was treating addicted physicians. Now, addicted physicians are a difficult bunch. Okay, apart from anything else, seriously. They have a personality construct that makes entrance into recovery very difficult. They also inhabit an environment where preconceived notions of addiction that are wrong, they have been immersed in. So they come with this preconceived notion and a personality construct that wants to make them extremely independent. They are difficult to treat. You know what the success rate is after 5 years? Of complete abstinence from everything? Over 80%. Why? Physicians like to say because we're smart. No, actually, Hazleton down in the United States did a similar thing what they do with physicians. And they found that the lay population who aren't physicians have the same results. So what's different? Well, we have the Physician Health Program, the PHP, with the Ontario Medical Association. 5 years of randomized urines. We have case management. We have to go to mutual aid groups. That's AANA, whatever. We have to go to something called caduceus, which is a support group for health professionals, because I treated nurses. One of my biggest component of health professionals is nurses. They don't have that kind of support. We also have to have an addiction physician that they have to meet on a regular basis. It's required that they go see a family doctor. How many doctors want to go see a family doctor? They have to do that, and they're checked up on. They have the recovery capital, let's say, with respect to a job and the sense that they have something worthwhile in life, which helps, but that's part of recovery capital. But they have this embracement of long-term support. That's why they succeed. Now, if we could build something like that for the ordinary person who's struggling, who doesn't have any recovery capital at all, like I said, you take them into treatment. I heard one person say it's like taking a tree that's dying, putting it into a nice new soil, watering it, and then pulling it out, putting it back into place that you first took it out of. That's what treatment does a lot. Have something to help. Yes?
I have another question, and it's not directly related to opioids, but it's related to addiction as a whole. And what do you think about the term of, like, the addictive personality, the person who goes from one type of addiction to another type and may fall into opioids, may fall into gambling, may fall into other things?
That's a good question. First, the reward pathway of the ventral segmental area to, let's say, the nucleus accumbens operates at all levels. Same way. That's why people say, well, listen, doc, I'm stopping opiates, but I'm going to continue doing cocaine. It ain't going to work. Eventually, you will settle back on the drug you like or get addicted to something different. We know that. They all have the same pathway. Similar with, like you said, the behavioral addictions that they talk about. Those that are genetically predisposed to this, they're on their way. And many I have treated, amazing, is I have treated people over a long period of time, and you get someone who came in for alcohol, then comes in for opiates, then comes in for gambling. I think what it is this. For example, the way that I like to describe it is the addiction is not external. If you were to have a glass of wine, you'd feel happy. If I was to have a glass of wine, you can bet that for the next 3 months I'm not going to show up for work. Something, it's not the wine. That's why people say, you're Puritan. Do you want complete banning of everything? No, I'm not saying that. But that's a good question. What it is that genetically, there's a commonality.
It's in that brain reception system.
Exactly.
Triggering, right?
Something that's triggering it. That's why it's not the drugs, really. Yeah, certainly they have the potential, the different ones, but it's actually the makeup of a human being. For example, and you can talk, and just let's say for my own recovery. Now, when I inject Dilaudid, I don't fall asleep. I go and paint my house. I'll go for a jog. There are many people who are in long-term recovery who tell you the same story.
I have to think about Jack Kerouac all of a sudden.
Oh.
I just have, can I add one?
Can we answer the question that's on
Sure.
the chat?
Oh, sure.
And then we can clap here. Is that okay, Adam? So, Dorothy's asking, what are your thoughts of Brantford being identified as having the highest opioid use in the province, and do you think it's related to the fact that we don't have a treatment center in the city?
Good question. I don't know. Maybe. I can't sort of, correlations and causality. I don't want to get into any trouble with that. But you got Hamilton too. Doesn't really. They have some stuff up on the mountain there, what we call the mountain. But that may be part of it. I think it would be great. Like treatment center, we've got to think outside the box. Yeah, it's nice to have a building. It's great to have somewhere detoxification. Great to have some inpatient. I agree with that. Is that the reason why? Maybe. It could be. I don't know your demographics well enough to be able to sort of. I'm straying outside of my area of expertise. But maybe that's one of the factors. Maybe other things too.
Adam?
Oh, for example, wait a minute. And just to answer that question, that's a good question. Because has anyone here been to BC? Like there's a lot of addiction physicians who are colleagues of mine out there in BC. They got tons of treatment centers. Tons. Makes us look, the paucity of treatment centers in Ontario is ridiculous. Yet they have a problem. So what gives there? What's happening? So, that may be part of it. I don't know. But that's a good question.
More of the harm reduction injection sites, right? Is that what you're referring to?
Well, no. They have a lot of treatment centers. A lot of treatment centers out there. Actually, a new one's opening up right now. So the thing is, they have quite a few. And that's one thing that my colleagues from British Columbia, who are addiction docs too, have been doing this for many years. It's one thing that they are amazed at. Ontario doesn't have that. So I don't know if that's part of the reason why you have such a high rate, or your demographics. I don't know Brantford well enough to tell you that. Sorry, I interrupted.
It's okay. No, you had another one.
So So my other question is just, what do you think about Gabor Mate and his kind of approach to dealing with addiction, and he's written, The Realm of the Hungry Ghost?
Listen, Gabor has done great work. I'm not going to take that away. He deals with a very difficult population, there's no doubt. I think anybody that does this kind of work, and in his book, I really do like his book. It's great. If you get a chance to read it, please do. There may be some areas that we may have some differing opinions on, but his heart's in the right place, you know, and he's trying to do the best that he can. And so, to tell the truth, I think someone like him who is endeavoring to help some of the most marginalized people and some of the most difficult people, I take my hat off to him. I have nothing but good to say. Although we may differ on some points, and that's all right. You know what? See, if we only have one opinion, then someone else is doing the thinking for us. I think we have to have different opinions. That's the way addiction is going to grow. So I have no problem with people having different opinions in mind.
We have time for just one more question online, and then but if you want to carry on after.
Yes, sir.
So for public health, we're in the business of health promotion and prevention, right? So I'm sort of looking at it from a different angle, and here's some of the maybe protective factors for people in order to prevent them from going down this road of addiction.
That is a great question. I'm going to give you an answer you're going to hate me for, I think. Okay? First, people have asked me, won't you go to high school and talk about your addiction experience and your recovery? I said, no. Because I know how teenagers think. Their prefrontal cortex isn't totally developed. That's, you know, I would not jump into a pool with a great white shark. A young teenage boy says, well, maybe, right? Okay. What they get, the message they get is that, well, he made it. He made it. So it gives them almost license. This is what we have to do, I think, okay? Disagree with me if you will. I hate the thing about stigma. People say, we shouldn't stigmatize this. Wait a minute, let's look at this. You've got families that have endured some of the most horrendous insults that this disease can throw at them, and they say, don't stigmatize it. The person's sick. No, I think what we have to do is what they did with smoking. Don't stigmatize the human being. Stigmatize the disease. And they were successful with smoking. Now, listen, I've been off cigarettes for 6 years. I love smoking. There's no doubt. So I'm no sort of Puritan. But what they did is they didn't stigmatize the person. They stigmatized the event. So smoking got to look at something as you're first unhealthy, then you're immoral in one way. You're polluting everybody else. And now it's sort of like, you know, you're an outcast. I think if prevention is something, how we do this, I have no idea. But to get the message that, you know, it's not cool to be stoned. Because I'll tell you, with drinking, which is really, and this is something, drinking has basically stabilized and gone down, except for two groups. Females between the ages of 19 and 24. Binge drinking has skyrocketed. And we know alcohol affects females physiologically far worse than it does males. And women over the age of 35 also increase in hazardous and risk of drinking. So, how do you know, having, like I know they're having a problem with this in England too. How do you get the message across that, you know, taking a drug ain't cool? Because I'll tell you, a 17-year-old boy doesn't think of death. They don't think of, as far as they're concerned, someone who's 26 is an old man. Right? So, I don't know, in public health, I don't know how you do that. But I think, let's see if we can take a look and see, what did smoking do? How did they do that? What did they use? there's some really effective commercials. One that always sticks in my mind was a young girl in front of a mirror who's taking a drag of a cigarette, and all of a sudden she gets all these wrinkles in her face. That's what smoking does to you. Young girls would say, no, I don't want to look like that. That was effective. My goodness. Anyways, that's my, I don't know if I answered your question. I don't know what you do. It's very difficult because, you can't, one thing you can't say to teenagers is don't use. You can't say, listen, when I treat patients, when they first said, the first time you used, it was great, wasn't it? They said, absolutely. Okay, let's not deny that. After it doesn't become very good. So maybe get some lessons from the anti-smoking because they did a great job. What is it now? I think 19%. I think of the population smokes. Is when I was a young kid, it was like 55% of the population smoked. That's amazing. Like wow, that's incredible.
Okay. We're going to pause here. We're going to thank everybody who's online, and thank you everybody online and on the chat, and for everybody coming. If you want to stick around and have more conversation with Dr. B, that's great. If you can turn this off, that would be fantastic.